Bom, pessoal, muito bom dia. Hoje é um dia muito especial para nós. Vamos dar continuidade à nossa série de webinars. E hoje nós temos uma convidada muito especial, que é a Mariann Aaland. Ela vai falar para nós sobre o tema das boas práticas em cirurgia ambulatorial e experiência na Noruega e o papel da enfermagem, das enfermeiras na cirurgia ambulatorial. Então, apenas para falar um pouco sobre a nossa apresentadora, ela é uma enfermeira intensivista por formação, treinadora de líderes de equipe e atualmente é chefe da Unidade de Cirurgia Ambulatorial do Hospital Universitário de Akershus, que é vinculado à Universidade de Oslo, na Noruega. Atua em cirurgia ambulatorial desde 1997 e como chefe da unidade desde 2009. E desde 2017 e até atualmente é a presidente da Associação Norueguesa de Cirurgia Ambulatorial e também uma membro da comissão executiva da Associação Internacional de Cirurgia Ambulatorial. Coordena a comissão organizadora do Congresso Internacional da Sociedade Internacional de Cirurgia Ambulatorial na sua 15ª edição, que será realizada em 2024 em Oslo. E nós, da Sobracan, pretendemos estar presentes ativamente nesse congresso. Well, ladies and gentlemen, I was just introducing Mariann yourself for our audience. And please, the word is yours.
Thank you so much for the nice invitation and welcome to this presentation. As you said, my name is Mariann Aaland and my topic today is about good practice in ambulatory surgery in Norway and the role of the ambulatory surgery nurse. You know, Norway, it's a small country. We are about 5.3 million people. Earlier, until 2002, our national health care system was divided into counties, and after 2002 it was divided into 4 health regions. And where I'm coming from is the down part. You can see the yellow part, and in the small part on the right side, that's where I am, my hospital is, and it is very close to the capital, Oslo. The surgery healthcare in Norway is divided into different kind of health of hospitals and health systems. We have the university hospitals, we have the regional hospitals, we have the local hospitals, some private hospitals, and also a bit of office-based surgery. And you can see the first building there. This is the university hospital where I'm working. So why the day surgery and where did Norway start? Because we are all starting somewhere and it takes time to develop. Our problem when we started was that the list of people waiting for minor surgery was long. And it was obvious that something had to be done. And as you are doing now, we were also looking to somebody who did it before. And in our case, it was England that started. Then some Norwegian pioneers showed up. And our politicians understood quite fast the benefit of this concept. And I must say the anesthetists, they played a very important role in both in the start and in the developing of the day surgery concept in Norway, both because they were very engaged and other also they were on the case all the time to get the better drugs to make the patient sleep faster and wake up faster, which is very important in the day surgery cases. And then we were starting the Norwegian Association of Ambulatory Surgery, NORDAF, about 25 years ago. It is an interdisciplinary team focus. The doctors, the nurses, and hospital leaders is all together. We are 8 in our board, and we are from all the teams in the day surgery. And where did we start? What kind of surgery did we start with? I would say we start with minor gynecology. We started with the minor orthopedia, children with hernia, and minor urology. So, as I said, look to others. How do they organize? That's what we also did. There were also, we found out it was important to analyze the negative forces, because there are always resistance against changing. So you have to find what is the important negative forces that you are dealing with. And of course, what we did was we started simple and safe, because you don't want to have the really bad newspaper headings concerning a new development. What we also learned from England was that if we want to start a unit, it is supposed to be separate from the rest of the hospital. That way you will keep the concept better. There is supposed to be a low threshold for admission in the start. And then to start a project, it is very important to have the enthusiasm and also maybe some incentives for the key personnel. For the patients, I think the criteria should be in the start ASA 1 and ASA 2. It should be established diagnosis, elective diagnosis, and the patients where you already have a surgical plan. For the adults, especially in the start and in the beginning, there should be an adult at home, and also to join the patient on the way home. And short distance to the hospital or to be able to get some help is also in the start important. For the surgeon criteria, it's supposed to be no transfusion expected, no invasive surgery like in thorax, abdomen, or head. The prolonged procedures in the start I think it's better to wait with those. No post-operative drains and minimal risk for post-operative complications. And about the anesthesiological criteria, it's most about the post-operative period. The patient should be awake, oriented, and mobilized. He should be able to have the peroral analgesia and not intravenous treatment after leaving the hospital. And also no or minimal nausea and able to drink is a start. That is very important. Now, after 25 years in trying to do this, I would say about 60% of the elective surgery in Norway are day surgery. We also have some office-based surgery with specialists where the patient are paying everything themselves or the insurance is paying, and those are not included in this 60%, so they come on top of that. There is a big difference in what the different hospitals do as day cases. And as you can see, the difference is based, for example, on geography. If you see the red ring I put around this blue part of the country, if you see on the right, that part is islands. And you see the down part, that is the big picture of it. And you know, when the ferries don't go after 11 o'clock in the evening, it is not good to have a tonsillectomated person in one of those islands. So that's why some of the patients should stay overnight at the hospitals before they go home. But we also do day surgery in these islands, or send the patient back to these islands. The gynecology, we have a lot of treatment as day cases, and in our hospital, more than 90% of the gynecology is day surgery, and it works very, very well. The new trends, we started now some in our hospital 5, 6 years ago, is the sub-emergency orthopedic cases, like hands, ankle, finger fractures, after reducing swelling. To be sure that the Norwegians are making their goal, the goal is that it's supposed to be equal healthcare for everybody in Norway, no matter where they live. And then you need some benchmarking, and they made this healthcare atlas, which is comparing health service in Norway. They are making data from several parts in the healthcare, and one of the cases is the day surgery. And they do this upgrade of this atlas about every 3rd year or so. So these numbers are not quite new, but I think they are quite similar in 2020 as they were in 2017. They selected 12 day surgery cases. And I'm sorry that there are also the Norwegian spelling of it, but the English is on the left side. There is shoulder surgery, meniscus, hallus valgus, carpal tunnel syndrome, selected hand surgery, tonsillectomy, paracentesis with drain, cataracts, eye lifts, hernia, various wounds, and hemorrhoids. In bed patients in these 12 cases from 2013 to 2017, you can see there are not so big differences those last years, because we already did a lot before 2013. What you can see is that the tonsillectomies are fewer now, not so many now in the hospitals. We are doing more as day surgery cases. What is also in this illustration, the red ring is the day surgery, and there is the percent, for example, for the shoulder, it's 74% is done in the day surgery. And if you see the lower line, there is about hemorrhoids, and you can see that 33% is being done in the day surgery. But if you see a little bit to the right, you can see a number there with 4,435. That is actually polyclinic. That means we don't do this in day surgery anymore. We do them in polyclinic with only local sedation, incisions. So what we try to do is to give the patient the best treatment on the lowest possible health care level. So what is, from our point of view, the benefits with day surgery? I think first and foremost, it is the patient satisfaction. We feel that our patients are very happy with day surgery, especially after a while. And now, as they got used to it, and they are also expecting their surgery to be simple, and then they want to go home the same day. We have the very, very focus on the patient safety, of course. We have the low risk of hospital-related infections, because you are not staying overnight, so the hospital infections will not be there. It is the efficiency. There is the simplified logistic. We have the specialized nurses. We have the standardized equipment, standardized procedures, standardized anesthesia, standardized patient flow. And there are also a lot of educational benefits in both quality and quantity of training, especially at the university hospitals, because our junior doctors and so on, they will be able to appear in several operations, equal operations every day, rather than one surgery session now and then during a period of time. It is also a compressed hospital stay, and there is less need of in-bed units. And the less need of in-bed units is, of course, one of the things being taken into consideration, because sometimes the units want to keep their beds, and sometimes it is a struggle that you have to downsize the amount of beds and do things differently. As I also told you earlier, the patient selection is related to the ASA classification. And when we started the day surgery, our patient was ASA 1 and ASA 2. Now I would say ASA 3 is welcome. ASA 3 plus is also welcome, but they should have a talk to an anesthesiologist before they come to the surgery that day. But it takes some time to develop it. And when you feel safe that the more difficult patient groups could come into the unit, it's okay, but you should be prepared for it. There is also the quality and the benchmarking. Sometimes that is, especially the benchmarking, is not so easy, because some hospitals or some clinics do different things, so it is a little bit difficult to compare. That's why also the Norwegian Atlas, they just put 12 different cases, so they could compare in those cases. But some of the local benchmarking could also be the not show of the patient, the cancelled surgery on the day of surgery in percent, not planned admission, not planned readmission, complication rate, patient satisfaction, health outcome, the total outcome. Also the economic, of course, it's playing a big role, and the stability, satisfaction, and the sick leave among the employees. And then is this the perceived quality? What do the patient want? Do they want to stay at the hospital, or do they want to go home? From my point of view, I heard so many patients say it is so good to go back to your own bed and have your own coffee on the bed next morning. So then I will tell you something about the nurses' role in the ambulatory surgery. And this is a picture from one of our theaters in Oslo. This is a musical theater. And you know, the stage is similar to the stage we are having in an operating theater. And every year we have the 9,000 day cases, and this theater takes those 9,000 when it is full. So this is the amount of patients that we're doing surgery to every year at our unit. And our performance is supposed to be at the satisfaction of all of them. This is a boring slide, but it is just to tell you what kind of surgery we do at our unit. For the ENT, we do the PCT, the tonsillectomy, microlaryngoscopy, septum rhinoplastic, inner and outer ear. For the gynecology, we do the revisio to the hysterectomy and almost everything in between, like the stress incontinence and so on. As I told you, more than 90% of the gynecology is done day surgery. For the vascular and the thorax, we do the various vein. I just put a little mark on that because now we do most of the various vein in the polyclinic with radiology and ultrasound and so on. So we don't do them in the day surgery with anesthetic anymore. In our unit, it is only the sedation and anesthetic patient who is at our unit. We also do some catheters for dialysis and cytostatica and so on. I must say this dialysis catheter is it's a good thing to do, because these are patients that is, for example, having cytostatica, and they don't have any time to spend at a hospital. They want to be at home with their loved ones. So they just come to us and get these catheters, and then they can go home again until they are supposed to have their treatment. Also for the orthopedic, we are doing a lot. We are doing shoulders, ACL, microscopic laminectomies, knees, ankles, and etc. And we also do the emergency, these cold cases I was mentioning earlier. We do the radius and ankle fractures and Achilles ruptures. With the urology, we do the TURB and P. We do the biopsies, sacral nerve stimulation, ureterorenoscopy. We started a couple of years ago. It also works fine. For the gastro, we have the cholecystectomies, hernia, sacral nerve stimulation is also quite a lot in our hospital. We are a center for that. We also do the dental treatment, children and grown-ups with HC, most of it with some kind of handicap. This is the public part of the dental treatment. Most of the dental treatment in Norway is private. We also do mama and endocrine surgery, like breast cancer, hemipterygiectomies, and various plastic surgery. That is, most of it is reconstructions and removals after surgery for cancer. We don't do cosmetic surgery at our hospital. So what are the factors, as we see it, to the success for our unit? We would say the 4 factors that we think is most important is that we have the very specific management. There is one leader. There is our own healthcare providers. We have the mercantile cleaning staff. All is in one unit, and we think that is there are clean lines. It is not hard to know where to go if you want some changes. Facilities, we have our own operating theaters with the specific doctor is there the whole day. And as I told you, the care providers, the nurses are only staying at our unit. They don't go shift in the main building. We have 41 beds pre-post operative, and 20 of those, about half of those, are for monitoring, and the rest are for resting, for arriving, and for before they go home. We also have our own equipment. Our surgery equipment is our own. That means we take a little bit more care of it, other than if it was to share with the rest of the hospital and the main operating theaters. And also our equipment is more simplified and more structured than we are a little more strict about this nice to have. It is more that we say, this is what we have and this is what you have to use. So, and then the doctors, the surgeons, they get used to what we have and what we normally use. Of course, we are not very strict, so negotiations are possible. I think also the culture is very important, especially at our unit. It's quite big. So I think the culture where everybody is working against a common goal is very important. We have the vision in our unit. It is very simple. It said day surgery center, satisfied patients. In Norwegian, it is rhyming. In English, it's not. I'm sorry about that. It is also the attitude for the people who is working there. And the most important thing we do is in our unit is that we are working as team. To tell you about the nurses in Norway, I have to tell you something about their skills, because I don't know what kind of skills your nurses have in Brazil. Maybe it is even better than ours, but I know there are different kind of education levels. In Norway, we have the intensive care, the anesthetist, and the operating theaters nurses, which all of them have the bachelor degrees 3 years. And also on top of that, they have 1.5 years with the special education at the university. And if they stay at the university half a year extra, they will have a master degree. Or you can make the master degree in a year, then you have some practice beside the theoretical part of the master degree, writing the main subject. Some of the pre-post-operative nurses are bachelors without the special education, but then they are very well experienced. But in the operating theater, all of them are specialized. And also the nurses managers and all of us, we are specialized nurses, and most of us also have the management education on the top of the specialist education as nurses. This is our organizational chart. You can see on top there is the avdeling leader of the unit, and that's me. Under me, I have a leader for the surgical nurses, one leader for the anesthetic nurses, one leader for the pre-post-operative nurses, and one for the secretaries. And also under the section for anesthetics, we have a coordinator who is coordinating all the 8-9 operating theaters, is also helping with everything. She's really the nav in the wheel. But only the nurses are employed in the unit. And I have also the anesthesiologist to be the medical advisor for the manager. And he is also a member of the leader team. But all the surgeons, we have a contact surgeon from all the units, and they are connecting with us. But then it is on the section leader level. But for the planning and so, it is on the avdeling unit manager level. In the day surgery, you never know who you are about to meet. And of course, this patient, all of them, they need different kind of treatment. And I will say it is so important to make the patient pathways tailoring and not assembly lines. If the patient feel that they are on an assembly line, you will not have a happy patient. So the goal is the patient, and you are not supposed to lose sight of that goal, even if you want to be very effective, even if you want to do a lot of things. The goal is the patient, and if you don't succeed with the happy patient, then there is not a succeed. In the day surgery, in the morning when the patient arrives to us, you will only get one chance to make a good first impression. And you will only have one chance to do the right thing for the right patient every time. So it is so important that the nurses all the time know what to do, how to handle, and they get so experienced. So this is natural the acceptance of the patient and to get the trust for this patient, it is vital. And of course, to have these good plans to get as much as possible done in one day, you need to think logistics. And I would say patient safety and all those things are very, very important, but the logistics is what make the difference between in-bed unit and a day surgery unit. So the smooth pathways is role number one. Of course, in the morning before the patients go to the surgery, they are supposed to talk to the surgeons and marking the leg and so on. And they are having also their last preparation from the nurse and from the anesthetics. But the nurses are the main role, and then they call the surgeons and the anesthetic doctors when the patient are more or less ready. The anesthetic nurse is bringing the patient to the operating theater. And of course, if the patient are able to work, they will walk. This girl, she came to us just for the pictures. So we let her stay in the bed and she was very happy about that. Also, the anesthetic nurses, as the national rules in Norway, it says that there's supposed to be two people able to do anesthetic in the room when they start the anesthetic and when they stop the anesthetic. And for the ASA 1 and ASA 2, it is quite all right that this is 2 nurses. You don't need to have the doctor in the room. In ASA 3, they say that the doctor should be able to also should be called to, but not necessary in the operating theater. And of course, the safe surgery checklist, I guess you are very, very familiar to that. We were very happy to get this list, and I normally say that this list is it's for the surgery, especially for the day surgery. This list is what the wheel is on the car. You just need it. You cannot do the surgery without the list. And I think it saved a lot of lives. So this is starting the anesthesia and preparing the patient for the surgery. As I told you, two anesthetic nurses are most of the time starting the anesthetic in our unit. And of course, the teamwork to make each other skills. I cannot tell you enough how important that is, and I have the respect for each other and the respect for each other's part in the team. Surgical nurses assisting in the surgeon, it's normal. Sometimes they have used the camera and so on. And I would say also, as I said earlier, the university clinics, they have a lot of learning situation for several groups, doctors, nurses, and so on, in the operating theater. And when you are a new anesthetist, you will have 2 weeks to go together with one experienced anesthetic nurse, just to learn the basic things about the logistic and also about the equipment. Even if I was supposed to tell you about the role of the nurses, I have to say something about the cleaning staff. We have our own cleaning staff, and they are keeping the time between the patients very short, and it is so important that they are playing their big part in the team, because it is all is connected like a chain. At the post-operative, the skilled pre-post-operative personnel, they are the key role in the day surgery unit. And they get so experienced because they have so many patients every day and every week. So it takes a blink for them to see if the patient is ready to go home or not. And we can see that there are almost none who is not ready to go home when these nurses say that they are. And the nurses' preparation, of course, in emergency situations, they should be skilled about complications. There is the knowledge about the emergency procedure for the equipment, about the drugs, how to handle, how to use it. and also where and when to call if there is emergency situation, and awareness of the role. The nurses has a lot of input in the service. They are a part of planning for the quality improvement, and if you are a part of developing something, it will also give you the feeling that you really want it to be done the right way. So it is important that all the steps are joining in the quality improvement of the unit. The written procedures, most of the procedures are written by the nurses, but they are controlled and accepted by the doctors. We have the educational plans, we have the systematic registration of accidents, and we use the registrations for improvements. We also have the systematic information pathways. We know who is going to call the patient, who is going to be in charge of the information leaflets, and so on. There should also be audits from the leaders, just to check up if everything is as it's supposed to be. And of course, the surgical equipment, it's supposed to be updated, and the nurses has the main responsibility for doing so. And I think the areas of responsibility for skilled nurses is important, because then you will have the responsibility feeling for the service. And of course, the patient satisfaction service, the information leaflets for all kinds of surgery, safe surgery checklist, and controlling the use of it. Already told you about those. This is the patient information. This picture on the right is from the hall in my unit. The trolley to the right is the emergency trolley, and the trolley to the left is the information leaflets. And I would say these two trolleys are equal important, because for the patient, when they are in the hospital, we should have this access to emergency equipment. And when they go home, they are supposed to have the information schedule as their lifeline, and also the contact information, so they know where to call if something's not right. And it is supposed to include information related to the diagnosis, wound care, and complications. What I also have to say is that most of this information should be given to the patient before they arrive to the day surgery, because all good pathways in day surgery started a long time before the patient come to the day surgery unit. It is starting when the first talk with the doctor who knows that the patient is going to have the surgery, because the patient who know that they are going home in 2 hours after the surgery, they will do so. If you tell them that they are staying overnight, they will do so. This is just an example for what the information said about, for example, the medication. This is also the post-operative talk. The surgeon will have a post-operative talk with information from the surgical and from the nurse before they leave. We have discharge routines, and the protocol allows the nurses to decide when the patient is ready to go home. We don't call the doctor to check if the patient is ready to go home. There are some discharge criteria. We don't use all of them, but this is a list what is to take in consideration depending on what kind of surgery it is. But some of them are main. They're supposed to be awake, of course, orientated and stable. They're supposed to get rest almost by themselves, because they are going home and taking care of themselves. They should be suitable for transportation by car, and no expecting complications. Able to eat or drink depends also about what kind of surgery they have. We don't expect the tonsillectomies to eat, but we want them to drink or have an ice cream before they go. Urinate depends also on what kind of surgery they had. And the nausea, sometimes they do have the nausea, but it is supposed to be not more than they can go home and feel quite okay. And also the pain, not more than expected. We don't say that the patient should have no pain before they go. We want them to have some pain. That sounds, I wrote that wrong. We don't want them to be in pain, also in trouble with the pain, but it's quite okay that they can feel that they have had the surgery, and it is supposed to be taken in consideration what they do after they get home. Also, the acceptable travel distance from home, it has also something to do with our geographic, and also who they can go to for help if needed. And also having a responsible adult present for the first night is it's good, and especially for the more major surgery, that is important. Most of the patients, they can go home as soon as they feel okay. Some of the major surgery patients, we want them to stay 3 hours in the post-operative unit. There is not a national standard for this, but for our hospital, we said that for the tonsillectomies and vaginal and laparoscopic hysterectomies, for example, we want them to be maximum 1 hour drive from the hospital. And 1 hour drive, normal drive, means about 20 minutes with an ambulance if needed. We also do the checklist at discharge. This is a little simpler than the one I showed you earlier. This is from our unit. So this is a normal day at the day surgery unit, and you can see the patient is arriving at 7 in the morning and leaving at 12 o'clock about with the last talk with the surgeon. And why did I put those times there? It's because the average stay in the day surgery unit in Norway is about 5 hours. That means some of the major surgery are staying longer, and some of the smaller minor surgery are much faster than that. But patient satisfaction survey should also be a natural part of it. It's important that the patient tell us if they are happy or not with what we are doing. Also, I give you an example for an information brochure we made for children. This is so we want the children to be prepared when they come, because if the patients are prepared, even small or older patients, it is important for their stay and their recovery that they know what they are going through. So this is some pictures from our information brochure. Thank you for paying attention.
Thank you very, very much, Mariann. You gave us such a wonderful lecture. It was so complete, and you left not so much to question because you were so clear. You did it so simple, so straightforward. But yes, I do have some questions I have prepared for you.
Yeah.
So, yes, sometimes ago, like a few weeks ago, I have read a paper which was called Establishing a Multidisciplinary Daycare Surgery Department, Challenges for Nursing Management. It was a paper from Norway. It was published from Ms. Ola Oygarten. I'm not sure whether this is the way I should pronounce her name. And she conducted a very interesting study on the challenging theme of culture change and teamwork. This regarding the establishment of an ambulatory surgery unit. And she describes how an entire unit moved from within the hospital to become a freestanding unit. So I feel that maybe it's all about your unit. I know you are involved in a project like this. And one thing that impressed me very much is that resistance came from those who should lead the changing process, as the most experienced nurses and doctors. Could you comment about culture changing and how to break resistance within the group?
You know, I said something about it in my presentation too, that some of the doctors and also the nurses, they feel that they have a big, nice unit when they have a lot of beds. And of course, if you make a day surgery unit, you don't need that much bed anymore. I did not tell you earlier that I also have a satellite unit. I have a big unit in the main building, and we also have a satellite building with 4 operating theaters. It is very easy when it is established, the small units, because then they live their own life, and the doctors go there, they stay there the whole day, and they work very well together all the time. In the main unit, we have the problem that the doctor have a lot of things to do. So sometimes they have to run away to see the day before patient or to send somebody home and so on. So I think that the problem is mainly to make everybody see the benefit of having both the unit that is the logistic well-performed unit, where you can do a lot of things, but still take care of the patients in a good way. And also you need to let the patient who is in need of a hospital bed stay there. But of course, as an intensive care nurse working at an intensive unit earlier, I must say the changes from the intensive unit, where you are taking care of the patient every minute of the day, night, evening, all, and then going to letting a patient go home after 1.5 hours. After it's not easy, so it is the mindset. But I think it is so important if you have a group standing together wanting to do this, and it is also very important that this includes the leaders, because the resistance cannot be too much, because then you will lose the motivation to do it.
Yes, yes. And I don't know, but here in Brazil, we used to say many years ago that big incisions make great surgeons. And so some surgeons, they just want to make all those very complex procedures, even though that the daily basis procedures are quite simple. And that's what, so patients shouldn't be in a structure, in a very big hospital that was planned and designed for those 10 or 15% of patients that need really big procedures. And they don't have to stay overnight, for example, because the culture of the team and the culture of the institution makes him stay overnight. So it's like I said, having a coffee next day morning at home, at bed, maybe this is the way to go. And, well, yes,
if
please,
I can just put in, when we started hysterectomies, it was quite a big challenge, because everybody thought that it was dangerous to send home the hysterectomies. So of course we did a project on that, and so we called the patients the day after, and they have we did some research about it actually, and 92% of those patients, the first 50 patients, I think it was, they said that they would do it again this way, or they would tell their friends to do the same, because this was a good way to do it. So I think also to ask the patient how they are, it will also influence the decision makers.
Well, you were quite clear in your hints and tips for everyone who wants to follow Norway's steps in order to succeed in ambulatory surgery. And you highlighted safety and organizational aspects. So what are your particular advices to Brazil and to us, to Sobracam, in order to get success in this journey?
Oh, it's a big question. But I think to create the organization like you did, and do it in the team, to be together and talk about it, and also to get the politicians because it's all about initiatives, and money is also in it, of course. So I think it is important you have something to show. You have to show some business cases, and you have to show what other countries did, because that's what we did. We told what England did. And we also now every year since the NORDAF started, we have an annual meeting every year with, we are not so many people, but we have about 300 or 400 people in our congresses every year. And we invite the politicians' leader. We invited every year the prime minister. He has not been there yet, but actually that's not right. One of the prime ministers has been there, but that was before he get to be a prime minister. But we invite them, and they will always send some of the high up in the system bureaucrats to join our meetings. So we have a dialogue. So we tried to, you can say, have a point in every level. So we to try to say that this is a good way, economical and patient safety, to do this.
Very, very nice points. Well, while you were talking, and we were talking among ourselves, some questions arose. For example, what is the average time of cleaning of the room, of the operating room, between procedures? And how do you select a nurse specifically to work in the day surgery unit? Does she have to have any special or essential characteristic in terms of personality, in terms of skills? How do you manage it?
First, to your question about the time between the surgery and the cleaning, it depends on what kind of surgery it is. If you have a tonsillectomy and you are only having the part of the area, we do a very, very short cleaning. And I think between one and the other patient, it is only about 5 or 6 minutes. And you just clean what you have to clean, and then you put up the new one, rewash, and then it is like that. But for example, major surgery like breast surgery for breast cancer and so on, you need a little more cleaning because you have open wounds and so on. It could then take about 15 minutes, but it depends, and the cleaning personnel, they know what they are supposed to do between the patient in every operating theater. So there is scheduled times for them. About the nurses' skills. I think the motivation to do things this way is very, very important. If you are an intensive nurse, as you know I was, and then you say that it is not patient safety if you send a patient home the same day, she will not be working at my unit. You have to see the possibilities, and you also have to be a part of the team. I think that is the most important, the respect for the others in the team, and you have to show that personality. That's important. And of course, tempo. You need to have some energy.
Okay, thank you very, very much, Mariann. I would be delighted to be a few more minutes or hours with you, because I have so much to share with us. We are very excited about your presentation.
Thank you.
And I was just vocalizing as well my colleagues from Sobracam. We did in this teamwork activity before this meeting. We have discussed what should we ask, and every aspect of this questioning about you. And so I would like to thank all of them as well. And on behalf of all my SoberCam colleagues to thank you very much once again, and to wish you and NORDAF a great Congress in 2024. And we hope we will be together with you at Oslo.
You are so welcome to join us in Oslo in 2024. And hopefully we also can work a little together until that time. I think there is a lot we can learn from each other. Not only you learning from us, but we can also learn a lot from you, I'm quite sure. And good luck to you and you're starting up your day surgery units.
Thank you
very much.